Welcome to this explainer. Today, we're diving into the incredibly complex and frankly devastating world of neurologic involvement in HIV and AIDS. It's a dense topic, for sure, but we're going to unpack literally every critical textbook detail step by step so you understand exactly how this virus attacks the nervous system. To really grasp why this matters, just consider this absolutely startling reality. Only about 5% of patients who die with AIDS have a normal brain on autopsy. Yeah, just 5%. That means a massive 95% of these patients suffer some form of structural neurologic impact by the end of their disease.
Because we aren't skipping a single detail today, here's our roadmap. We're going to cover the general neurologic impact, the primary effects of HIV, dive into some CNS complication data, look closely at toxoplasmosis and lymphoma, break down PML, and finally, review the clinical guidelines for neurosyphilis.
Okay, starting with Section 1, General Neurologic Impact. Broadly speaking, 40 to 60% of all AIDS patients will develop neurologic symptoms. But here's the kicker. For a third of those patients, a neurologic complaint is their very first presenting symptom. It's often that initial glaring red flag that something is systemically wrong. When breaking down the top focal CNS lesions, the main mass-producing culprits, toxoplasmosis is leading the pack by a mile at over 32%. Following that, we've got cryptical abscesses at 13%, primary CNS lymphoma at 4.7%, PML sitting between roughly 2 and 4%, and finally TB at just a fraction of a percent. Moving right along to Section 2, Primary Effects of HIV. We really need to separate opportunistic secondary infections from what the HIV virus does all by itself. The most prominent direct hit from the virus is AIDS encephalopathy. This is actually the most common neurologic involvement across the board, hitting about 2/3 or 66% of AIDS patients with CNS involvement. But it doesn't stop at encephalopathy. The virus directly causes AIDS dementia, sometimes called HIV dementia complex, as well as aseptic meningitis. Remember, these aren't secondary bugs sneaking in because the immune system is down. This is the HIV virus directly causing the damage. We also see direct nerve damage basically everywhere else. We're talking peripheral neuropathies, AIDS-related myelopathy, which actually causes this literal vacuolization or hole formation in the spinal cord, and cranial neuropathies. And a really fascinating little detail here, that cranial nerve involvement can occasionally show up as bilateral Bell's palsy. Crazy, right? All right, let's jump to Section 3, CNS complications data. Looking at a major 320-patient study on secondary complications, the main takeaway is the sheer dominance of non-viral infections. Sure, viral syndromes like subacute encephalitis happen in about 17% of patients, but Toxoplasma gondii just vastly outpaces everything else at over 32%. You've also got neoplasms like primary CNS lymphoma at 4.7%, and stroke and infarcts bringing up the rear at 1.6%. Which brings us nicely to Section 4, toxoplasmosis and lymphoma. Let's isolate those two heavy hitters. Toxoplasmosis typically strikes late in the HIV timeline, usually waiting until those CD4 counts totally tank below 200 cells per cubic millimeter. It overwhelmingly shows up as a mass lesion or abscess. In fact, it accounts for a staggering 70 to 80% of all cerebral mass lesions in these patients. But just keep in mind, it can also present more broadly as meningoencephalitis or encephalopathy. On the flip side, primary CNS lymphoma, or PCNSL, pops up in about 10% of AIDS patients. The absolute key association you need to file away here is its strong link to the Epstein-Barr virus. Okay, Section 5, breakdown of PML. We are doing a deep dive into progressive multifocal leukoencephalopathy. PML is caused by the JC virus. Now, this is a ubiquitous, small, non-enveloped polyomavirus with a closed circular double DNA genome. It's definitely not a prion disease, so don't confuse it with Jaco-Creutzfeldt. Actually, it's so incredibly common that 60 to 80% of adults already walk around with antibodies to it. What's genuinely fascinating about the JC virus is that it's entirely opportunistic. It only manifests as PML when the immune system is severely compromised. Today, AIDS is the most common underlying cause. But historically, before AIDS, it was chronic lymphocytic leukemia and lymphoma. We also see it in allograft recipients taking immunosuppressants, patients on chronic steroid therapy, and folks with autoimmune disorders like lupus. Down on a cellular level, PML's pathology is totally distinct. It actively strips away myelin, causing focal demyelination specifically in the white matter, but it actually spares the axon cylinders. What's left behind is a cellular wasteland of enlarged astrocytes and these really bizarre oligodendroglial cells packed with eosinophilic intranuclear inclusion bodies. You can spot the virus using electron microscopy, and while it prefers the cerebrum, it does occasionally pop up in the brainstem and cerebellum. Clinically, it's devastating. The disease is rapidly progressive, usually leading to death in just a few months. Though, very rarely, someone might survive a bit longer for reasons we don't fully understand. There's no effective treatment. Patients come in with mental status changes, blindness, aphasia, and worsening motor or sensory deficits. And a quick clinical pearl for you. Seizures are actually quite rare with PML. When it comes to diagnosis, you're stuck between a rock and a hard place. A brain biopsy is definitive, with a sensitivity anywhere between 40 and 96%. But we rarely do it because, well, it's highly invasive. Alternatively, checking the cerebral spinal fluid using a PCR for JCV DNA is highly specific, but sadly, it really lacks sensitivity. Finally, let's wrap up with Section 6, Neurosyphilis Clinical Guidelines. HIV completely rewrites the rulebook on neurosyphilis timelines. Usually in non-immunocompromised patients, neurosyphilis is a slow burn, taking 15 to 20 years to develop. But HIV throws gas on the fire. AIDS patients can develop neurosyphilis in just 4 months after infection. And terrifyingly, it can happen even if they received what would normally be perfectly adequate treatment for early syphilis. To fight this hyper-accelerated timeline, the CDC pushes highly aggressive protocols. Symptomatic or not, the primary treatment is just massive, frequent doses of penicillin G IV. We're talking 3 to 4 million units every 4 hours for 10 to 14 days. An alternative primary is penicillin G procaine IM with oral probenecid. If they have a mild beta-lactam allergy, you can pivot to Rocephin IV daily. But if it's a severe allergy, no easy swaps. Penicillin desensitization is strictly required. So, taking all this dense data into account, here is what you should really walk away with. With neurologic involvement affecting up to 60% of patients and causing such a rapid, devastating decline, how could earlier intervention and much stricter neuroscreening protocols fundamentally reshape these fatal outcomes? Think about that.